Okay, so before we begin, we are really thrilled and excited to have Rachel and Dr. Laitman and Dr. Mandel talk to us about innovations in clozapine therapy. Now, Rachel is an SMI advocate, and she is, she's a chemical and biomedical engineer who became an advocate for families struggling with serious mental illness after a member of her own family achieved recovery, which is such a common story of why we become so passionate advocates. And then Dr. Robert Laitman practices internal psychiatric medicine in New York City alongside his wife, Dr. Ann Mandel Laitman, and is a co-author of Meaningful Recovery from Schizophrenia and Serious Mental Illness with Clozapine, Hope and Help. So with that, let me go ahead and I'll mute and turn it over. What I'll do is, would you rather, I think we talked about it, would you rather go through your material and then take questions? People can chat.
Yeah, I think so.
Okay.
I think that makes sense. Let me
Okay.
start my screen share.
Okay. And if we have any disruptors, I can mute them for you.
Okay.
Okay. Thank you, Rachel. Take it away.
All right. Can you guys see my presentation here? All righty. So thank you for the introduction, and thank you for having me. And thanks again to Dr. Laitman and Dr. Mandel. My name's Rachel Streiff. As mentioned, I'm a engineer and a Six Sigma black belt. I'm also the data analyst for Team Daniel Running for Recovery from Mental Illness. Dr. Rob Laitman and his wife, Dr. Ann Mandel, started that organization. I'm also a clinical assistant for Josiah Nwakwa. I work 1 day a week as his REMS designee and assistant over there at Psychs and Health. And that's a clinic in Phoenix. I also mentor a lot of families. I'm kind of known as the SMI mom. And there's my kiddos. I've 5 kids, big family, and we've got some pretty cool recovery stories going on. Recently, just a self plug, I have an article published in the Journal of Clinical Psychopharmacology. And this is the May-June edition. It just came out. Institutional neglect of anosognosia is a critical barrier in the treatment of psychosis-related disorders. And then Dr. Rothschild, the editor-in-chief, also submitted an editorial on my commentary. But the best part is that I did a podcast with the editor and Dr. Julia Koretsky, and I had a great time doing that. It might have been politically incorrect, but it's a good listen, and I'm pretty proud of it. So what are we doing here? I'm here to talk about clozapine, and I'm pretty passionate about this. Clozapine is the only medication, keyword only, FDA approved for treatment-resistant schizophrenia. That is a condition that is officially when 2 antipsychotics, traditional antipsychotics, have failed to produce an adequate response. We call that treatment-resistant schizophrenia, and that's what clozapine is used for. It's also the only medication FDA approved for reducing the risk of suicidal behavior with schizophrenia. So it's an important medication. And I've got an amazing recovery story in my family related to this. This is my son. He's a handsome guy. There he was in high school. We had a tough time after high school. This came out of nowhere, no family history, no psychiatric history. In 2019, schizoaffective disorder with anosognosia. I'm fortunate enough to live in a location that has court-ordered treatment. That's ultimately how he was able to engage. And we were able to get early intervention with clozapine, and he has since made a full recovery. He has no symptoms and no side effects. He is back in college. He's got a year left. He's getting 2 degrees. He's a rock star with good grades, and he's just back to his normal self, and he's happy. I need a better picture because he's lost even more weight since that picture. So I have invited here today two people who are some of my favorite people. I My son's life and livelihood to this couple, Dr. Robert Laitman and his wife, Dr. Ann Mandel. They have been internists. They've been practicing internal medicine for decades in New York, and their practice changed dramatically after their son Daniel, the inspiration for their organization, Team Daniel Running for Recovery from Mental Illness. He recovered from schizophrenia with a clozapine approach, and they have dedicated their practice to families like mine. That all they do now is clozapine for patients with schizophrenia or psychosis related disorders. These are some dedicated doctors who care, and they're a little different than what we normally encounter in amongst doctors and psychiatrists. This is Dr. Laitman and members of his team finishing the Boston Marathon recently. And here's a little snapshot of our weekend Zoom. These doctors open their homes on Saturdays for their patients and families to come visit, and then have a Zoom every other Saturday to support families all over the world. And we love them, we're grateful, and I'm just excited that they're here with us tonight. So I'm going to be borrowing some slides from some of Dr. Laitman's previous presentations. Most of these I've prepared for them as their data analyst. They have a clozapine-centered clinic. It's not a first episode clinic. And it's also, I know they get known for a clozapine first approach or advocating. We say that a lot. That's not really what their practice is about, although they'd love to do that first. But they have 180 patients at the end of 2022. Now I think it's close to 200. And they have a 94% rate of continuance with clozapine. They follow a clozapine-centered approach. About half of the patients come to them already on clozapine. They're just still struggling with psychosis or side effects and need an optimized regimen. The other half are brand new to clozapine. There are families like mine that were desperate to find a provider that would prescribe this medication. So they really specialize in treatment-resistant and clozapine-resistant patients by definition. That is their practice. Some important books. Lori mentioned Meaningful Recovery from Schizophrenia and Serious Mental Illness with Clozapine, Hope and Help. Dr. Laitman and Dr. Mandel are co-authors along with their son Daniel and Lou Opler. And then also the Clozapine Handbook is another great resource. Just plugging these, I've got several copies at home. So that's by Dr. Meyer and Dr. Stahl. So our journey, how did we get on clozapine? So my son was assigned to a community mental health clinic here in Arizona, and that was important, and he got a little bit better. He was on risperidone, Abilify, Zyprexa, Latuda. We've heard it all, and he was better, but not really. You know, he could have a conversation. He seemed okay, but he couldn't work. He couldn't go to school really. It was really quite devastating. And I asked the doctor about clozapine because I had done my research, and that community clinic doctor said, "Oh no, that's a very dangerous medication. We only do that as a last resort." And then they said, "Why would you want that? He's doing so well." And I know now that the bar for recovery is so low that, you know, sitting on a couch staring at a wall was kind of a success. And then, you know, that maybe that is for some patients, but I had hoped for more. The other thing evident in that community clinic was that clozapine was only being given to the sickest patients. 500 or 1,000 patients and only 20 were on clozapine. So I went beyond our community clinic. I asked a second doctor. They just said, "Well, we just don't do clozapine here." The third doctor looked at me like I was crazy, said, "Clozapine? No one does that anymore. There's newer, better medications now." The fourth doctor said, "Well, your son's not a candidate. We can't do that with court-ordered patients or that have poor insight or might be non-compliant." Doctor number 5 was a winner, and that's Dr. Terry Vaughn. She's in Prescott, Arizona, and that's 2 hours away from me. We couldn't find anybody in the Valley. And she's been doing clozapine for decades. She's been following Dr. Laitman's methods since before Ann and Rob even had kids, I think. So she's, and we love her, and she's a wonderful psychiatrist. So why am I so passionate about clozapine? And it's the data. Right here, we're looking at a diagram that is a pictorial representation of important meta-analysis that came out in 2013, 40,000 individuals. The efficacy of clozapine is vastly higher by a lot compared to every other antipsychotic. There was another version of this analysis in the Lancet with more medications added over the years, and they all fall into that same little bubble of efficacy. Clozapine stands out, it's more effective by a lot. And then after 2 traditional antipsychotics have failed to produce an adequate response, clozapine is 5 times more effective than the second best. It's often the only medication that works. So this is real data. This is thousands of people. And then this one. This is another important meta-analysis that came out in 2019 by Masuda, 63 cohort studies, over 100,000 patients. And what they found was that the sickest patients that were treated with clozapine fared better than the rest, despite having a higher severity of illness. And I've made a little picture of what that study found of over 100,000 patients, that although the sickest patients were given clozapine, they ended up better off than just the regular sick patients. Not only that, they were far more likely to continue the medication. So it's not just more effective, it's a lot more effective. And what the Team Daniel practice is finding is that this large leap, it's not just an incremental difference in effectiveness, it's a leap. And for most patients, it's the difference between being able to work or go to school or disability. And this was the case for my son. Historically, 14% of individuals with schizophrenia are able to work or go to school. Very low rate, 10 to 14% in the US. New Zealand, where they have a good rate of clozapine utilization, and almost 40% are working and going to school. The Team Daniel practice with 120 patients on clozapine after 1 year, 3 out of 4 are engaging in 20 hours a week of school or work or meaningful activity. There is a direct correlation between functional recovery and the utilization of clozapine. Not only is clozapine effective, it's safe. It's among the safest of all antipsychotics. 62,000 patients, we call this the FIN20 study, over 20 years, showed that clozapine reduces all causes of mortality and adds 10 years over other antipsychotics to a patient's lifespan, which is interesting because I'd been told clozapine was dangerous, and it turns out it's less dangerous than the other options. 45% reduction in cardiovascular deaths. I thought clozapine was dangerous for your heart compared to everything else. It's actually safer in that regard. The mortality rate for quetiapine, Seroquel, that doctors are giving out like sleeping pills, is twice as high than the mortality rate for clozapine. And then a lot less suicides. Again, the FDA indication for suicide, reducing the rate of suicide in psychosis individuals, which is 3 to 5% the first year, to that of the general population. So it's a very effective, safe medications, and patients like it. It's actually very tolerable. Patients stay on clozapine more than any other antipsychotic. Very little movement disorders, except in patients with a history of movement disorder. Clozapine is the best option in that regard. It does not elevate prolactin, doesn't create breast tissue. There's no erectile dysfunction, and it doesn't block dopamine the same way that traditional antipsychotics operate. Even very severe risks that we all associate with clozapine, cardiovascular, neuroleptic malignant syndrome, diabetes, agranulocytosis even, which I have a whole thing on, same as every other antipsychotic in terms of severe risk. So it's safe, it's effective, it's tolerable. Adherence is better than any other antipsychotic, including long-acting injectables. So when the doctor was telling me my son was not a candidate because there was a risk of non-compliance, and we can't do clozapine if they're going to be not compliant, if we can engage patients in treatment, if we can just get them started. Again, I'm only showing you very large scale studies, 8,700 patients on clozapine among 30,000 users, the best adherence, the top, better than a long-acting injectable. When patients get better, they take their medication. And my son hasn't missed a dose of medication in 4 years. And he won't. He feels better. He knows he's better. He's recovered, including from anosognosia. An interesting thing, I've pulled this from the Team Daniel slides, cannabis use disorder. Practices are starting to look at this for cannabis use recovery. There are no good treatments like we have for alcoholism, Vivitrol, for example, naltrexone, buprenorphine, I can't say it, but other for opioid medication-assisted treatment. So clozapine has a unique improvement in cannabis use disorder. And a lot of this has to do with the dopamine sparing aspect of the medication compared to other antipsychotics. So an interesting side note there. So if we were following the guidelines for treatment-resistant schizophrenia, which is 30% of patients with schizophrenia, we would have 30% of our schizophrenia population on clozapine. And they're doing that in advanced countries, Australia, New Zealand, even China's at 30%, Europe, over 20%. What's going on in the United States, guys? Less than 4% of treatment-resistant our patients, 85% with treatment resistance don't get this medication. We have a lower rate of clozapine utilization than third world countries here in the US. And it's a big deal. There's 500,000 people that Dr. Eric Messamore calls the American clozapine gap. 500,000 people who should be on clozapine, but are instead being treated with ineffective medications. And it's deadly. My conservative, low estimate, rough math, 2,500 people are dying in the United States every year. A large chunk are suicides, but a lot of it is simply the increase in mortality from having to treat treatment-resistant schizophrenia with inferior drugs. It's deadly what we're doing here. And why? You're right. Doctors are not following the APA guidelines. So 2 antipsychotics of sufficient duration, if they don't produce an adequate result, we should have patients on clozapine within a few months, certainly within the first year of treatment. But in the United States, they're going 4 to 8 years instead of 2 antipsychotic trials. Their average is between 3 and 5. I know my son was on 4 or 5 before we got to clozapine. Doctors are using polypharmacy, throwing multiple antipsychotics at schizophrenia. That is not the standard of care. And 20% of patients are getting that approach. And instead, we should be using clozapine. I find this unacceptable, especially when we know how effective, how tolerable, how safe this medication is. So the other tragedy with all of this is that when we delay starting clozapine, time is brain. And Yoshimura in 2017 identified a critical treatment window where the response rate to clozapine was 82% if it was initiated within 2.8 years of treatment resistance. The response rate dropped after that down to 31%. Another study showed in 2015 out of Turkey that the extent of delay in starting clozapine was an independent contributor to the odds of clozapine having a favorable response. Now, Dr. Laitman's here. He'll disagree with all of this. He will say, yes, it will take longer and it's a little more difficult if they've been sicker longer. But the impact of delaying clozapine treatment, which is an epidemic in this country, it's huge and it's deadly and it's devastating. And I'm going to change this. Okay. The angry moms are going to change this. Just wait. So 30% should be treated with clozapine. There are programs like Team Daniel, like Viewpoint Dual Recovery up in Prescott, Arizona. My son was there for 1 year. They have 80 to 85% that are being treated with clozapine. Silver Hill Hospital in Connecticut. So we don't necessarily have to recognize treatment resistance or wait. We can use clozapine because it works, and we should. So why aren't we using it? I've just shown you the data. No one argues this. Even the APA agrees. It's not because of efficacy. It's the gold standard. It's not because of safety. It's saving lives. And it's not because of tolerability, because patients like this. Okay, why aren't we using it? Well, it's inconvenient. And I've got a pretty good list here of clozapine inconveniences. And that's what today's presentation is about. Innovative efforts that we've made in dealing with these many inconveniences with clozapine therapy. So the elephant in the room, I've got a lot of slides on this. The excessive, quote, mandatory blood tests that aren't even really mandatory, by the way. Of course, there's no long-acting injectable. That's tough. Adjunctive meds are needed. Clozapine cannot be taken by itself, and that's more so than other antipsychotics. Requires an internal medicine approach. Some consistency is needed with clozapine treatment, a little more than other antipsychotics. You can't just start and stop clozapine, even though that happens all the time. There's no standard dose. This is a challenge. You can't just follow a set prescription guideline, and we shouldn't. It's actually dangerous. We have to get serum levels. We need to get a measurement of clozapine in the blood of each person and understand how their unique absorption and metabolism works with clozapine. So we can't just go by dose. We have to go by serum levels. This inconvenience, it's very inconvenient. The product label and the prescribing guidelines for clozapine are severely outdated. They're 30 years old and they're dangerous. And I'll talk more about that. It also takes a long time for clozapine to work. My son had no effect until 3 months in, and then he just kind of snapped out of it and has been getting better ever since. There is a strong interaction with tobacco smoke. Alternative forms of nicotine don't have this strong interaction. Even vaping is preferable to smoking. It's the hydrocarbons that interact with clozapine and reduce its effectiveness. And then lastly, there is an increased need for sleep, up to 12 hours per night. And not all programs are real accommodating of this. I know my son slept 12 hours a night for the first year of clozapine. Today, he only needs 9.5. And so it gets better over time, but that's a tough one. It is tough. So that's why clozapine. I've given you why clozapine. How do we eliminate those inconveniences? How do we get where Dr. Laitman and Dr. Mendel are at, with 94% that continue with clozapine and 74% able to return to work or school? How do we do that with such an inconvenient medication? Here's a really important, we're going to go to science, okay? Here's an excerpt. I know it's confusing, but this is from a paper that was published in 2020 by Jose de Leon, titled "A Rational Use of Clozapine," is the short version of the title. And he talks about the CD ratio, which is the clozapine serum level relative to the clozapine dose. And he's done a ton of characterization on this, and he documents that Some patients have a CD ratio as high as 7. Other patients have a CD ratio as low as 0.39. I talked to a patient the other day that was down to 0.3. This is critical to understand, and unfortunately, many practices don't. Here is an example to make this a little easier. Suppose I have an individual with a CD ratio of 7. That means if I give them 200 milligrams a day, their serum level is going to be 1400 nanograms per milliliter, likely toxic. This person will get very sick potentially with 200 milligrams per day. On the other side, I have a person with a CD ratio of 0.39. If I give them 200 milligrams a day, their serum level's only going to be 78. That will have zero effect. They will be effectively untreated. So according to De Leon, the potential characteristics of our high CD ratio individuals, they're more likely to be Asian, obese, non-smoking, and or female. And then the low CD ratio individuals are more likely to be Caucasian, lean, male smokers. I've looked at the Team Daniel data every which way. I don't see any correlations. It's rather unpredictable. People fall all over the spectrum, but there is a subset of patients that we call the tall, skinny, white kids, okay, that require a very high dose of clozapine to be therapeutic. Now, I suspect that the reason the prescribing guidelines are so far off with respect to this, because 50 years ago, those guidelines were based on skinny white men. And this is going to lead into an entire history of discrimination, and I'll talk about that. But here's why this is a problem. And if you look at the prescriber's guideline for clozapine, the dose titration recommended has patients at 150 to 200 milligram daily dose at the end of the first week, and increasing each week by that amount. So if I have an possibly Asian, obese, non-smoking female, for example, and we give them 200 milligrams of clozapine, we escalate that fast the first week, she could die. So this is very dangerous. And since those guidelines, which haven't changed in over 30 years, more reasonable approaches have been published. And the Team Daniel approach is to increase no more than a daily dose of 50 milligrams each week. So some doctors might call this a microdosing approach, where we increase by as little as 12.5 milligrams. Viewpoint Dual Recovery with Dr. Terry Vaughn, also doing this slow microdosing approach. This is why I have families call me and we talk, and I say, what about clozapine? They say, oh, we tried that already. They tried that in the hospital. He got really sick. The side effects were terrible. She couldn't move, couldn't get out of bed. This is an epidemic in hospitals. They titrate way too quickly, sometimes following the guidelines, right? And they're allowed to, but they're trying to move patients out quickly, and the results can be devastating. And the problem we have is that we've just sabotaged that patient's experience with a medicine that might save their life and their livelihood. So we have learned that these prescriber guidelines, the outdated clozapine label, we need to go very much slower. We need to treat the side effects and measure serum levels to understand if we can go faster with that patient, or if we're going to need to slow down. By the same token, I have families saying, well, clozapine didn't work. They only got worse. They just were completely psychotic. Those are the patients with the very low serum to dose ratio that they probably didn't get enough medication, and they probably yanked the other antipsychotic right out from under them. So it is vital for hospitals and doctors to understand the dynamics of clozapine dosing. When clozapine is increased too quickly, we get myocarditis, severe orthostasis, body pain, people can't move, seizures, bowel blockages, this drooling that can turn into aspiration pneumonia. elevated heart rate that creates anxiety and is bad for your heart, right? Severe sedation, vomiting, neuroleptic, all these side effects that happen, that it's not clozapine, it's because they titrated too quickly. Even neutropenia, which Ann and Rob have never seen in the Team Daniel practice, even that appears to be related to fast titrations, especially in hospital settings. So this is, I've done a lot of analysis of serum levels. The Team Daniel practice, they love serum levels. This is just an example of how there is no standard dose. Schizophrenia spectrum patients, 87 of them, ranged from 25 milligrams to 900 dose of clozapine. Now we're talking milligrams, this is a dose. Bipolar disorder patients from 12.5 to 550. So there's no standard dose. And then the serum levels, which is more important, the median serum level was 640, which is kind of on the high end of the traditional limit. But what they're finding is that 25% of patients need to go higher than the traditional boundary of 1,000 serum level. And so a lot of the clozapine resistant cases, or individuals who've been told that, really just need a higher serum level, and some may even need to go up to 1,700, but that's 25% of patients. So one can achieve these higher therapeutic doses and higher levels of clozapine if it is a slow process and if the side effects are treated. The main side effect with these high serum levels is seizures that we worry about, and all of the patients where we challenge those upper limits are on medication to prevent seizure. All right, I love this one. Side effects, especially with patients that have anosognosia. For a long time, all I heard from my son was, these medications don't do anything, they just make me fat. And you know, that might have been true, okay? So there's my adorable young man before he got sick. There's the antipsychotic induced weight gain. That's rough, right? So Dr. Vaughn added metformin. All of her patients that start clozapine, almost all, are starting on metformin. And there's my son. I think he's lost even more weight since that photo, but he looks just like his skinny little brother, right? So, he's a walking success. So the average number of prescriptions in the Team Daniel practice is 11. And that's not even counting all the over-the-counter medications. So my son is on 9 medications. Now, if we were to ask, if you can have your brain fully restored, go back to work, go back to school, be happy, have minimal side effects, would you take a little cup of pills in the morning and a little cup of pills at night? Yes. Engaging patients to taking oral medications, we've become pros. It can happen. So what's interesting, look at this Pareto of medications. There's laxatives, there's lamotrigine for seizure prevention, 80% of patients, stool softeners, multiple medications for weight control and alertness. Everything that's orange on this chart is not even a psychiatric medication. Nausea, beta blockers for elevated heart rate, drops under the tongue for drooling. Most of this is an internal medicine approach, which is why Dr. Laitman and Mandel are so good at this. This requires a medical approach, and that's what you see here. Very few medications that are psychiatric in nature. Some interesting additions to the top Team Daniel medications in 2023 that hasn't been published yet: oxytocin as an adjunctive medication, and memantine. Both of these improve mood and focus and alertness. Very interesting, very innovative. We're following all the best science. Weight control is a big focus in Team Daniel. I had to pull these slides out of their presentation. So only 22% of their patients gain more than 7% body weight when they join the practice. Historically, clozapine and olanzapine, 35 to 45% of patients would be experiencing that level of weight gain. Team Daniel, the only ones really gaining weight are those that need it, because when we break down the weight gain by the weight class, overweight and obese patients on average lost 13 to 34 pounds, whereas the skinny kids gained 10 pounds and they probably needed to. Very innovative approach. At the end of 22, Team Daniel had 40 patients on the GLP-1 agonists. You've probably seen the commercials for Ozempic or Trulicity. This is a weight chart, very effective at treating antipsychotic induced weight gain. Here's another chart for a male patient. And this is the overall distribution of obesity among the 40 patients that received, that have been on this treatment in their practice. These patients, 73% of them were obese. At the end of 2 years, only 40% are obese. And you can see the shift in the distribution of the weight class. Many of them are not even considered obese anymore. So this is a very powerful tool that doctors should be using. We should be doing everything we can to treat and prevent weight gain in these patients. Cigarette smoking. No one's going to believe this, right? Kids with schizophrenia, they're all smokers and we just let them smoke. Well, that's not the Team Daniel approach. And remember, clozapine interacts with smoking. So we try and get patients onto other options, other forms of nicotine, or get them to quit altogether. Chantix, 87% of Team Daniel smokers are being prescribed Chantix, and they've got a quit rate of 2/3, which is higher than healthy subjects trying to quit. Chantix, varenicline, it got a bad rap in 2008 when it came out that allegedly suicidal ideation, different problems. Well, it turns out that none of these things happen in schizophrenia patients. The Eagle study in 2020, a subgroup of close to 400 schizophrenia patients had very high abstinence rates with varenicline or Chantix, and there was no increase in neuropsychiatric adverse events. Another study in 2011 that showed varenicline actually made some cognitive improvements in patients that took it that had schizophrenia. It turns out that the reason patients with schizophrenia smoke is because it helps parts of their brain, the nicotinic receptors, and varenicline does the same thing. So they actually have some improvement in negative symptoms. And there was no suicidal ideation or significant depressive symptoms as a result of varenicline. And there's my kiddo. He's nicotine free thanks to this method, right? And he's also now varenicline free. And he's even lost some more weight. Look at that adorable picture. That's him on his 23rd birthday. I'm forcing him to pose for the camera. Chantix is no longer available, but we can get generic varenicline. It's a great medication. You have to manage the nausea. My son was on this for 2 years. We don't follow the normal 2-month process. It takes years to stop the nicotine habit, and he hasn't been on varenicline for several months now. He is nicotine free. We're proud of him. So as you've seen, we're doing a whole person approach. We're doing polypharmacy. We're doing a strategic prevention of side effects. You can find this chart on the Team Daniel website. This is a simplified version of those things that I just talked about, how to do a microdosing approach, how to include these other medications. This has been very popular for families and doctors and providers. All right, the elephant in the room, the top reason psychiatrists are not prescribing clozapine, excessive blood work. It's terrible. I'll get into that. But the number 2 reason is a lack of experience in education, and we've got some solutions for that too. So in 1975, there was a couple dozen elderly Finnish patients that died, and clozapine was pulled from the market. It was reintroduced with a neutropenia testing scheme where we measure ANC weekly for 6 months, and then biweekly for the next 6 months, and then monthly after 1 year. That's a lot of blood tests, and it is a massive burden for patients. Theoretically, well, and it can happen, and it does happen. Clozapine can reduce neutrophil counts and cause neutropenia, which might lead to a life-threatening agranulocytosis and life-threatening infection. So on top of this excessive blood testing that is very difficult for many in this patient population, there is something called a REMS that is FDA mandated, that is an electronic surveillance platform that records patients' ANC measurements. And what it does, it enables pharmacies to block clozapine refills if you don't get your blood test, or if there's some other ridiculous problem. This system is actually pretty dangerous. If you stop and start clozapine, if you interrupt clozapine, it's a little bit different than other antipsychotics. It's dangerous to abruptly stop any antipsychotic medication. But with clozapine, you'll see rebound psychosis, catatonia, delirium, cholinergic rebound. We've seen seizures, cardiac events. Last month, we had a death of a young man in Texas. This was a national story. His clozapine was stopped. The pharmacy refused to dispense it, and he died. Also, what other medications are you aware of that when they're abruptly stopped, there's a risk of harm to caregivers? Okay, no antipsychotic should be abruptly stopped the way that people on clozapine are susceptible to. The number one cause is REMS blocking a refill because of errors or missing labs. It's not saving any lives that I have ever encountered. The second most common cause is hospitals not carrying clozapine in their formulary, quote, because of the REMS. This is actually a choice hospitals are making. And if I was a hospital right now, with the focus that's coming down the pike on clozapine discrimination and discrimination against treatment-resistant schizophrenia, I'd go get some clozapine in your formulary and start stocking it and start treating patients ASAP. This is not acceptable. This is discrimination against treatment-resistant schizophrenia. Other reasons that we see clozapine starting and stopping, and that we have to be careful, cheeking and then not cheeking and back and forth, right? Abrupt changes in smoking status. Docs had a patient that had a seizure because they just stopped smoking. Their clozapine levels went through the roof. Medication errors and interactions. There is an epidemic in Arizona right now of patients discharging from one facility to another, not getting their meds or getting the wrong dose. And we can't let that happen. We've got things in the works trying to improve accountability. So what is the deal? What is the risk of neutropenia from clozapine? Well, it's extremely rare and almost never fatal. This was an important characterization by Dr. Taylor in 2022 that found it's 0.23% likelihood of a potentially life-threatening event, but no one died in their 14-year study of thousands of patients. Most cases are not life-threatening. Most cases aren't even clozapine related. They saw no occurrences after 105 days. And this, it almost exclusively affected elderly patients that had underlying risk factors. And the conclusion is that mandatory monitoring is causing more harm than good. Well, no kidding. Ask any clozapine family. This is the data compared against the average age of onset. Old people. Sorry, I know 50 is not that old, but the median age for agranulocytosis caused by clozapine is 50. Who's getting sick? 20-year-olds. Who benefits from clozapine? 20-year-olds. We are excessively testing for a non-issue. We've created a ridiculous barrier to clozapine treatment. It is ridiculous. It's dangerous. It's costing lives. For every life allegedly saved by all this routine testing, 1,000 people die from lack of access to clozapine. That's what the numbers show. We've got to do better. And the FDA, they know this, and they're a little bit under the gun right now. This is their data that was published in 2018, 90 million Medicaid, Medicare subscribers between 2000 and 2013, rates of neutropenia. Clozapine was very low, lower than this combination of really common medications. But look at this, olanzapine, Zyprexa, 5 times more likely to cause a granulocytosis or neutropenia in the age group 18 to 44. It's 5 times more dangerous in the group that actually needs this medication, right? The risks of neutropenia or a granulocytosis, the severe neutropenia, really only affect this elderly age group of 65-year-olds. Another important meta-analysis, a few thousand patients, 2019, the neutropenia risk for clozapine is no different than any other antipsychotic. And they said that this excessive monitoring of clozapine patients is just not justified. If you're going to do it to clozapine, then you should be doing it to all of them, right? So treatment-resistant schizophrenia, discrimination. I've put this lovely table together with the help of my friend, Bill Nyman. 6 medications listed here, all with higher risk, sometimes 10 to 100 times higher risk of severe neutropenia. Very vague requirements for blood testing and monitoring. None of them have a REMS. Clozapine has the most restrictive guidance of all of these. What is with this discrimination against mental patients? Would we ever inconvenience an arthritis or a cancer patient or a heart patient or a thyroid patient? No, but it's somehow acceptable to severely inconvenience to the point that a deadly barrier is created for patients that have treatment-resistant schizophrenia. And guess what? The FDA knows this. They had to suspend the REMS, and it's technically still suspended because in 2021, thousands of prescriptions of clozapine were blocked because of a system conversion that the FDA allowed to proceed with no oversight, no validation, complete neglect of this very vulnerable population. Don't get me started. But it's actually, they've suspended the program, but it's the way they've done it is making matters worse. This irritating pop-up appears in the REMS every time you log in, uses this bizarre verbiage that pharmacists are interpreting as more restrictive, not less. They've caused even more patient harm. And again, this young man that died last month. What we are seeing is that patients are more likely to be stopped or interrupted with tragic consequences than the testing is likely to prevent a granulocytosis at all. Who fails blood tests? Anyone with mild neutropenia below 1,500 neutrophils. This could happen to anybody. Mild illness, just normal day-to-day variation, over-the-counter antacids, arthritis cream. Sleeping a lot causes neutrophils to stick to the capillary walls, and then you get a low reading. Who sleeps a lot? People on clozapine. Being Black, African Americans, and people of color have naturally low neutrophil counts. They're actually less likely. 80% have this gene that makes them have lower neutrophil counts, but they're less likely to develop neutropenia. Blacks and people of color are wrongly discontinued from clozapine at a significantly higher rate than the general population. And again, it's because the 30-year-old guidance was based on skinny white men. It's outdated, and can you tell I'm a little angry? It's outdated. The label needs an overhaul. Who's failing for severe neutropenia? Most of the time, it's a lab or data entry error or other medications. Clozapine-induced agranulocytosis is actually pretty rare, but we are discontinuing people for the slightest variation in their neutrophil counts. All of this testing is causing more harm than good. Here's a common data error. It's happened to a bunch of patients in our Phoenix practice. Pharmacists who are wanting proof of labs are entering the data wrong. They'll put it in as 2.79 because that's how it's reported on the Quest lab form. Automatically blocks the refill and we have an interruption. It's ridiculous. So some caregivers like me are angry and have started this website, theangrymoms.com. You can check us out. And our motto is start using clozapine and stop interrupting it. And we've got to end the clozapine REMS. So check out the Angry Moms. A whole group of angry moms are going to be descending upon Washington, D.C. on May 24th for World Schizophrenia Day, talking to legislators. We're not stopping until that REMS is done. We're just done with it. Any doctors, prescribers listening, you've got to see this, please. The blood tests are not a federal mandate. The FDA knows about these problems. They know it's dangerous to interrupt patients. They put a way to waive labs in the REMS. Use it. You can waive missing labs. Do it. If the patient refuses the lab, or they can't get the blood draw, or they can't get to the lab, or they just can't do it, you can waive the labs. This is how you do it in the REMS. This is part of the patient status form. Use these options. Here is a very public case of Eric Smith. He had a featured story in People magazine back in February. He has arranged an agreement between his doctor, his pharmacy, and the REMS that he's only getting blood work every 3 months. He's been on clozapine for over 10 years. I don't think there's ever been a case of agranulocytosis on a patient that's been on clozapine for over 10 years. Why would we require monthly tests? So it can be done. We do not have to do all of these blood tests. Besides that, this whole entire discussion, my anger about the REMS and all this blood testing, we have this important innovation, probably the most important development for treating schizophrenia in the last 10 years, the finger prick monitor point of care device to measure ANC for clozapine patients. I've got one, and this is my son getting tested. It instantly gives an ANC result and automatically can be set up to automatically upload the REMS through your Wi-Fi. This is a life-saving innovation. This is allowing patients to do clozapine easily. Blood work at home, in clinics, in pharmacies. We need all the hospitals to have this technology. We've made it easy to overcome this immense barrier that's deadly and that's killing people. At our office here in Phoenix, at Sykes and Health with Josiah Nwakwo, we've got a finger prick machine, and we just do this at every intake. We do their standard vitals, their heart rate, blood pressure, temperature, weight, waist circumference, and we say, hey, let's go get a finger prick. We're just going to check you for signs of infection. We don't even talk about that this is for clozapine. We can send them home with their prescription that night. And then, all the other things we need to measure, we can do in a later lab. So the Athelis device, you can get one at home. The cost is $1,500. The test strips are $30. We have patients with very sick individuals at home. Parents are getting these. They're able to gently start clozapine with these kids. There is a way to get a discount if you can go through Golden Gate mail order pharmacy and get name brand Clozaril approved by insurance. You can get these devices for as low as $500 or $10 test strips. All devices are being distributed through Golden Gate Pharmacy, all the home devices. So you can go check that out. Devices in clinics and pharmacies, we actually have some in Arizona. To get more information, go to athelis.com, click the Get Started button. But there are 15 or 20 Genoa pharmacies in Arizona that have these devices. Now, it's a little bit more expensive for a clinic or hospital to get one because the cost is determined by the software and the number of users. However, clinics are able to bill for a 15-minute visit when someone comes in and gets the finger prick. And that's how a lot of these clinics are recouping some of this cost. This is a list of devices in Arizona that are at Genoa pharmacies and in private practices. I got this from the Athelis company. LifeWell is an SMI clinic that's doing 35 to 60 tests a month on their device. The caveat, the Genoa pharmacy has the devices, they pay for the devices. However, the patients need to get the testing done over in the SMI clinic. That's been holding up some of these devices from being used, I'm told. So we've got to get that fixed. These devices are FDA approved and CLIA waived, which means that they are not considered a moderate or difficult device. They are considered a simple device that anybody can use on their own. Now, why isn't insurance covering this? Mercy Care, I hope you're watching. Why aren't we covering this? Insurers. If a diabetes patient has a glucose meter for a finger prick that's covered by insurance, why wouldn't this be covered as well? This is a reasonable disability accommodation for a severely disabled patient. We need to get insurance coverage for these devices, and I'm working on that, and we've just got to get there. The cost of failing to treat treatment-resistant schizophrenia. Hospitalizations are between 1,000 or 4,000 a day, depending on if you have Medicaid or you have private insurance, and insurance pays higher, right? The indirect cost and direct cost combined of schizophrenia, $92,000 per person per year. A large study of veterans, 14,000 veterans with treatment-resistant schizophrenia. Clozapine saved $22,000 per patient per year and eliminated 18 hospitalization days per person per year. Another long-term study showed hospitalizations went from 6 times a year to less than 1 per year when patients were given clozapine. But beyond this cost effectiveness, we know we've really just got to end the suffering. How do we move forward? We know the number 2 barrier to treatment is lack of provider education and support. There is a large managed care plan, Medicaid managed care plan in New York that's launching a CME series this June. Dr. Laitman's going to be involved in training doctors in the management of treatment-resistant schizophrenia with clozapine. The target audience, of course, is those network doctors, practitioners, residents, and even pharmacists. In addition, this large Medicaid managed care plan in New York is developing a case rate for clozapine patients. This would cover the care management and coordination. These are difficult patients with a lot of requirements. The compensation is not enough. That is why we don't have enough doctors doing this. The first 6 months that require a lot more testing and a lot more management and targeting of medications will have a higher compensation rate. And then there will be an ongoing case rate reimbursed to providers to encourage adherence and keep that patient on long-term on clozapine. The reason they're doing this is because their Office of Mental Health that flags individuals who would benefit from clozapine, but they're not using it. And this is the data that is driving these kinds of change. I did some benchmarking here at Psych Zen Health with Josiah Nwakwa's clinic. He's seeing clozapine patients every Thursday, and I'm there with my device and I help them with their blood work. He's getting reimbursed between $99 and $109 for those clozapine patient visits. Compare that to a Spravato visit. He's being reimbursed $150 to $178. And I call this discrimination, okay? Those clozapine patients are not easy patients. There's a lot of prescriptions, 11 on average per patient. Weekly lab orders have to be sent, processed. The data's got to be reviewed, REMS entered. Remember, we also have to do the blood serum testing, targeting dose. This is a difficult patient population. We partner with families. We communicate. There's more phone calls. There's more management of adverse effects. These patients go to hospitals. They have to have doc-to-docs. There's a lot of changes. These are difficult patients. The support for prescribers and the compensation needs to meet what it takes to treat this population. So we're fighting for that. So in summary of all of our innovations in clozapine treatment that I've covered today, and then I'll hand it off to doctors, use a very slow titration. Stop following the clozapine label. Slow it down, microdose. This eliminates side effects and allows patients to have a 94% of continuance and success rate with this medication. Rational polypharmacy to treat the whole patient. We call this the Laitman protocol or the meaningful recovery protocol. We've got to prevent the complications before they happen, before they gain 70 or 100 pounds. I'm tired of sitting in front of a psychiatrist asking about metformin on behalf of a patient and being told, well, I don't prescribe that. Doctors, psychiatrists, they're trained in medicine. These patients need a medical approach. So now I've got to engage an internist and a psychiatrist separately. This is why internists are so good at clozapine, right? Most of these prescriptions are not psychiatric meds. We need to treat the whole patient. Their life and livelihood depends on it. 25% need higher serum levels than traditional boundaries. We have to protect those patients also from seizures. We have to use serum levels. Lastly, Athelis finger prick devices. These are a reasonable disability accommodation. We need to start using them. Insurers and payers need to start covering this life-saving technology. It's discrimination not to. Doctors, please start waiving labs. Don't let your patients run out of medication. Most doctors are prescribing a buffer so that patients don't have an accidental lapse and interruption in their patients. Chantix, guys, varenicline, start using it. It's great for this population. Stop with the Chantix phobia. Consider clozapine for cannabis use disorder. It's an exciting element of this medication that's kind of a new thing that we're using it for. And we've got to end the clozapine REMS. Last but not least, we've got to use science to guide all these blood tests and neutropenia monitoring. That's all I have. I'm going to turn this over to doctors. Thank you for listening, and thanks for everyone's patience.
So do you want questions now? We did have Dr. Olson on, and she had a lot that she would have liked to say, but she got called into court. So she will send her her comments later. But we do have some in the chat. I think the first one was from Dick, and it was in addition to concerns over side effects and consistency of use, what causes psychiatrists aversion to prescribing clozapine? Would have been great to have Dr. Olson on for that, because she could have spoke to it. Because remember, they only have patients for a short period of time.
Yeah.
And if they don't have a home to go to, like a lot of the people, they're not going back to a family or a home. They may go to group homes or halfway homes or homeless shelters. It's really hard to find them twice a day. So I think you have to look at the whole picture. I mean, I wish we had a system now that said you are sick with schizophrenia, therefore you can move in here and we're going to surround you with love and care and support. But that's not what we have right now.
Yes, I've got a dream, and this is a backup slide. My son had the opportunity to go to Viewpoint Dual Recovery Center for 1 year. And my dream is to create a program that Access will pay for. And this is a residential treatment program. I have it mapped out in my head. I need a millionaire or billionaire to show up and help me get this started. But we know what this looks like. We know how to treat patients, and it's different. The problem with a lot of these programs is they're short duration. They're based on addiction recovery. And what we need to do is treat these patients differently. And, I've got it mapped out here. it's, I won't go into it, but I've got a dream, and you're right. We need a continuum of care. We've got to take care of patients. They don't
Oh,
all have
yeah.
families. They don't
We-
all have support.
We also need the fact that we need secure, because if they're in the
Yes.
mindset that they don't believe they're ill, which, high percentage do, and they're in that initial state where you're titrating them up and they still don't think they're ill, they will run away. As many people's loved ones on this call, you can order them to or discharge them to a birth. They're not going to stay if they're ill and they're being made to take all these pills. So we do need our secure residential births, so you can stay for a period of a year or two. And but right now, I think it's difficult.
Right. I mean, the entire approach to psychotic spectrum disorders is incomplete. And, putting in a paper, something for you guys to look forward to, schizophrenia research. We're putting our protocol out with a gentleman by the name of Machary Keshavan, who's the chair of Harvard. And he loves acronyms. And the acronym that we're using in our approach is the EASE approach for clozapine. The E stands for early. Yes, Rachel, I do prefer early. And yes, I remember the Yoshimura study and, looking at that cutoff at 2.8 years. Again, a lot of the problem with clozapine follow-up in studies is they'll only follow them out 2 years. We have people out 10, 15 years. So early does make a difference because time is brain. But Yoshimura, I believe, is wrong, and it's just because he didn't follow him long enough. But having said that, the recovery is not as complete. So the early use of, doesn't that make sense? The most effective, safest medicine, it's only safe if it's done competently. So there has to be some education involved in this. But I think, if you're an oncologist, don't you have to know how to use chemotherapy? If you're a psychiatrist and you're trained to take care of people with serious mental illness, and you have 3% of the population with psychosis, and you have a treatment that can change the trajectory of the illness and restore the life of not a tiny number of 10% or so, or 15%, but of 70, 80%, shouldn't you be obligated to be doing this? All right, so early use is important. A, again, stands for aggressive monitoring for side effects. This is not an easy drug to use, but you learn. It's like riding a bike. The first time it's going to be tough. You're going to fall off. You're going to go off the path into a bush, but you'll get better at it. The one thing that really determines where clozapine is used is if clozapine is used in the community, where there's someone else to help. And once you get an experience, it really does become easy. Doctors are all about pattern recognition. So you have to see numbers. And that's why I'm really grateful, that people tell me their stories. And I hear more and more because we can't possibly take care of everyone that is on our Zoom call. We try to help, but at least we hear their experiences and it guides us. So having that aggressive approach, looking for side effects and aggressively monitoring. Anosognosia is part of that A as well. You have to be aware. You have to have levels. Half these kids will cheat. There's disintegrating clozapine, so it makes it much more tough for them to do that.
And you can get liquid if you
and you can get liquid if you can. I just heard the story from someone where they've just induced the kid in a coma. They actually put a kid in a ventilator because they could not control his behavior and have him on high dose Seroquel and Ativan. What are they doing? Shove a goddamn NG tube down the kid if you have to, and put him on clozapine. They already have a court mandated order. Sorry about my language. S, and I can't emphasize this enough. This is presumably a lifelong medicine. Not easy, lifelong. It's like the analogy I always use is if you have insulin dependent diabetes, you have to take insulin. If you have severe mental illness with psychosis, you're going to require clozapine. It's been
What
developed
does S stand for?
slow.
Oh, okay.
S,
Say it. You
it's
didn't say
slow. Oh, S stands for slow, sorry. So take your time. It's critical that you get this person on. Going slower really minimizes the side effects. And then E, which Lori alluded to already, is engagement. The one time you cannot do clozapine is if you don't have engagement. Because if you have a person that you're writing a prescription for, they're going to go out, take it one day, stop it the next. All you're going to do is drive psychosis. We know that if you stress someone, the rebound is terrible, but it's not only that. We know that psychosis is poison to your brain. It drives excessive, what's called central nervous system pruning. It stimulates microglia. Dopamine dysregulation does that. And that will be driven by the clozapine. You know, the kids who I've seen that have not done well, almost universally have been the kids that haven't been able to be engaged. So we need systems in place. We need, you know, if you don't have a family, we have to create one. I don't know if you guys probably don't read the New York Times too much in Arizona,
No, we
but
get it. A
you
lot
get
of
it.
us on it.
There
We
was
do.
that town in where was it? In Belgium, I believe.
Oh,
Griel,
Jill.
Giel, right?
Yeah.
Where that's their
It's
1500. Where is it?
Where is it?
It's I
It's, I believe.
Giel, Holland or Belgium?
Yes, Belgium.
Belgium, it is Belgium. So since 1300, it's been a tradition in this town to take in people with serious mental illness. It's essentially a foster care for the seriously mentally ill, but it's a tradition, and they normalize and they treat these people well. And Trieste, Italy
Yeah.
has a similar model, and they use a fair amount of clozapine, both locations, about 30–40%. But the whole idea of embracing these people and normalizing and treating them just like, my God, it's an organ in your body, it's your brain. You know, are you going to be prejudicial against someone with kidney disease?
But I think it's cultural too. So there is a group
Absolutely.
in California that went to Trieste, Italy, to study it, and they're doing a pilot program in LA. Now it'll be very interesting to see, can they recapture culture in the US, in LA, in the middle of everything going on there. It'll be an interesting experiment, but I strongly agree with you. The person has to have support. And so many of our young people with psychosis that are at that age, they've either burned all their bridges or they're far away from family settings and loved ones. It makes it difficult to treat unless we get these secure residentials or long-term stays where they cannot leave until they gain insight and stabilize.
Right, so we need better laws so that we can treat people long-term without them being able to say, I'm leaving, I'm gonna go, and we need better residential facilities where we can keep them longer than 3 weeks to, you know, get them on medicine really fast and send them home.
Yeah.
So it's,
We have laws. I mean, people are ordered to go into 24-hour treatments, but when you're taking your meds and you are psychotic, a court-ordered treatment means nothing to you. I mean, they're going to run off and hide from everyone that theoretically is their support team. So I think we need secure in one form or another.
And we need a better understanding. So a lot of these kids have quote unquote burned their bridges because they said, what a rotten kid this is.
No.
These are not rotten kids. Some of my kids are the sweetest, kindest human beings, but this is only after treatment. We've had kids come to me that are threatening our lives. I've had kids throw chairs, 220-pound ex-football players, you know, but that's the illness, for God's sake. But it's hard. It's so hard on families. So there has to be not only education of the providers, but education of the families. And there's so much learned hopelessness and helplessness.
There is something else that
That's a huge issue.
hasn't been mentioned yet that I think is a very practical problem. People with SMI very often have interactions, as we all know, with the criminal system. Okay, so if you have a person who is on this medication and they get pulled over, they are unlikely to get this drug when they're in jail. At least that's been my experience with SMI getting any sort of medications in jail. And this is a particularly bad one to come off of suddenly. And you have so many people that have that experience in this particular population. I hate to put in another practicality here that hasn't been mentioned, but I hate to have somebody die of a seizure in a jail cell also.
Absolutely. And, we always like to say people with serious mental illness are not violent. That's absolutely not true. People with serious mental illness that are appropriately treated and are on clozapine are not violent. That's absolutely true. But it's very common to have violence, and that violence is more often than not directed at family. Are you guys, Chuck, are you familiar with Justice Leifman? He's down at Miami-Dade County. He's done some really good work. And, so there are models out there where you have diversion courts and you bring these people into treatment. Again, it's frustrating because there are so many good models. We're one of those good models. And we're still trying to complete this because we've been trying to do it initially in the using insurance, and more recently, as we've continued to live off of our savings, have gotten out of all insurances just out of sheer necessity to survive. So there are certain frustrations out there, but there are amazing models out there, and it's just putting it all together. So a lot of this is getting past the nihilism, the belief that people can't get better. So that's why it's like throwing bad money, after, other good money. Just why do this? They don't get better. That's just not the case. So that's point one.
And Judge Leifman is also looking to put together a more of a community down in Miami-Dade. They're raising money to do residential treatment and build a big center where they can do all of this at once so that you can have a place where people can go long-term.
Right. It beats, it beats the hell out of building more jails. Right.
Can I hop in and answer Dr. Chern's question really quick?
Sure.
She's got a question about the Athelis device. And in fact, one of the COPA locations has an Athelis device. They just need to start using it. I believe it's the Phoenix location. The Athelis device is, it's so important to this effort. We do at Psych Zen Health, when patients come in for their first visit, we just do a finger prick just because. Right? It's like nothing. It's not a lab. We do it along with all the regular vitals when they walk in the door. It's really simple to use. The Genoa pharmacies have these devices. Frances was on, there she is. Her son is on clozapine because of this device. He is not capable right now of participating in blood tests, and they've been able to keep up the clozapine because they have this device in their clinic and they're using it. So the Genoa pharmacies have these. They need the SMI clinic side to help patients do their blood test.
And the unfortunate thing is, and this Dr. Chair, by the way, the unfortunate thing is that the cost is not paid for by access. So it's paid for by some private insurance.
Right.
And
that's
that
got to
prevents us from using it more often.
Yes, that's got to change. And I'll be taking this one up with access because it's discriminatory.
I've been looking for you. Where people.
Yes, I know. In fact, there is a COPA patient right now that's needing to start clozapine, and it's a barrier.
I have been talking and negotiating with Athelis for a long time, trying to figure out the finances of this.
Yeah.
So I'm glad to hear that someone will take it to access.
Yeah, they're trying to add it in OMH as well in New York State. So there's 22 sites potentially, and they're going back and forth and trying to get it approved. Because it's
Mhm.
just
Yeah.
another way of breaking down a barrier. Oh, and by the way, in Finland, not dozens of women. It was only 16 women.
Wow.
They were all elderly. And Herb Meltzer, who's one of the two gentlemen that brought clozapine to the United States with John Kane, went back and looked at that population. And it wasn't the frickin' clozapine. They were on other drugs, including Depakote, Tegretol, thank you, dear. And, and it was 8, and they were all elderly. So 16 women developed 8 grand, 8 died. And it was a small, Finnish village, not surprisingly, elderly women, the highest risk population on other drugs that are known to cause 8 grand more frequently than clozapine. It was just one horrible event.
And
So-
no one has challenged this on
Nothing.
behalf of these sick patients for decades. It's discriminatory.
Well, Herb went back and looked at it, and that was ignored.
So for someone who asked about a copy, we'll share the slides, Rachel. If you send them to
Yeah.
me, we'll put them up. I'll wrap them as a PDF and put them up. And then the webinar will also be on the site for those that have missed it. One other thing I was going to say, once a person can get stability and get insight and realize that they are ill, our son was fortunate enough to have 2.5 years in locked facility. That was after like 5 years or 8 years of running away and never adhering. And he is stable. He's not on clozapine, but he's very stable. He's kind of back and working and involved with family and things like that. So I think it's time and stability and insight to know, just like if you have diabetes, you have to take your meds, or heart disease, you have to take your meds.
Yeah.
Are there other questions that we did
One
that
other
we missed?
thing. Yeah, one other thing I wanted to bring up, because there's more recent data about showing why REMS really doesn't make any sense. Back in the beginning of the pandemic, we wrote a review article with recommendations on how to handle REMS during the clozapine. This was a worldwide group of us, 18 doctors all together, and we recommended every 3-month monitoring for patients. And now we have the data that's come back on that 3-month monitoring. And the question was, would we see a spike in severe neutropenia? The data back from the United States is there was none. The data just came back in from England. There was none. So it really, it makes no sense. REMS is one barrier that really should fall. And if the FDA just looks at the data, it's an absurdity right now. And as Rachel said, it is prejudicial.
So do you think, took a note when you were talking earlier. So I understand with getting rid of REMS so it doesn't block prescriptions and cause disruption. But is it your opinion that you have to do the blood draws to get the serum levels while you're titrating up to the target dose, and then after that just do it routinely? Is that what you want to change?
I like to do that. You don't have to do that. I mean, there are some people that are so phobic of blood draws that once you're good at this clinically, you can just follow along and negotiate. I mean, I have people right now that I'm just doing the Atlas device, and telling them, we're going to go up. Obviously, there's no toxicity. Clinically, you seem to be better. Your parents seen you as doing more. You're reading more. You can be a doctor and you use judgment. That said, anosognosia, cheeking the meds, or as Ronald Reagan said, trust but verify.
Yeah.
And so I do, yes, given the choice, I will monitor. But that doesn't mean that these kids can't still go for clozapine, even without the monitoring. You just have to use your clinical judgment there.
The angry moms have presented to some of the research groups by the FDA a proposal, and monitoring patients should depend on the patient. If someone is gravely disabled and very sick and blood testing is not an option, don't do it. Treat the patient, get them better. The likelihood of neutropenia is 0.23%, but the odds of them dying is like 5% the first year, right? Maybe higher even.
About 3 to 5%.
Right. And then
Right.
the other medications, they just check for a fever. If someone's running a fever, then you always do a neutropenia test. Some common sense needs to be applied. Is it a 20-year-old that the odds of neutropenia is 1 in a million? Why would we test that age group the way that we're doing? An old patient, of course, we should be doing testing. It really depends on the patient. And the Angry Moms have put a rational neutropenia monitoring plan together. We've sent it to the FDA, and we hope they listen.
But I think, not only I understand testing for that, but getting to the target dose, especially in the early stages when they may be smoking, they may be using other drugs, they may be cheeking, they may be doing all of that. I think that's when you at least have to measure serum levels initially.
Yeah, it's a guide. And, we always say, people say, oh, we're in the therapeutic range. But the range, as Rachel demonstrated, and in our practice, is tremendous. Now, we always talk about using clozapine with resistant psychosis, and we talk about that 30%. But the reality is a good percentage of people, and again, there's tremendous heterogeneity in psychotic disorders, but there is a very large percentage of these kids that are not returning close to their baseline, that are really not having meaningful recovery, that people have said, this is good enough. And that's what we're calling good enough care. And for us, that's not good enough. Too many of these kids can be restored to very close to their original baseline. It just takes a lot of time and a lot of work. I know your child is not on clozapine and doing well, but this is what I tell people. If you think your son has returned absolutely back to their baseline, God bless them. And there are kids that do this because, as I said, there is that heterogeneity, but the vast majority do not. And there's a very strong push now in the research circles to redefine what resistant schizophrenia or resistant psychosis is to more that model. And then you're talking 70, 80+% of people at least having a therapeutic trial with clozapine. So it really depends on how you're defining things. And again, a lot of people are still relieved to have kids reasonably stable, and I understand that. So there's two things that we do as physicians when you're treating psychotic illnesses, right? You relieve suffering. That's step one. And then the second part that we propose, because we are a recovery-based practice, we want meaningful recovery. We want these kids living lives of purpose. And I just went to a wedding of a kid on clozapine, and I just talked to a girl who told me she was pregnant on clozapine, and I've taken 3 pregnancies through on clozapine. I have 2 kids that just got their PhD, and one is teaching at a major university. There are incredible possibilities, or as I like to say, what's typical of people with schizophrenia? What would you expect them to be? Like my son, a stand-up comic, of course, and that's what he does. There are endless possibilities. Look at Rachel's, Connor. I mean, this kid's brilliant. Not Connor, Carson. I know. I said it. I said, oh my God.
All right.
Sorry.
Any other questions for the doctors or Rachel before we go to our stakeholder portion where families may be experiencing issues and they're looking for guidance?
There's a good question in the chat of someone 65 plus improving after using clozapine. If anyone knows this on this call, it's probably Dr. Laitman.
Yeah, no, I've started 3 people so far, and I have a phone call of a woman who's been bipolar since 18, had great support, but her mom died a few years ago, and she's 70 years old now and has come on and off of clozapine. So she'll be, I'm offering her to my NPs if they'll take her. But I don't think they will because she's going to be complicated and difficult and is a struggle.
What's
And
the answer?
so the answer is yes. And the three that I have ongoing, I have this other one. Well, she's younger. She's in her 50s, 52. But the other woman is 70. So I have just small numbers. Again, they've been sicker longer. There's certainly not going to be the same level of recovery. They're going to have more side effects. You can predict that. But having said that, yes, I've, the three, all the ones that got better came to me, one because they had bad tardive dyskinesia and were really still quite psychotic. Another person had failed all the other antipsychotics and ECT and were desperate. And the third just, had a suicide. So all really good reasons to use clozapine at that point. And all three are significantly better and are living independently and have not been hospitalized since. So yes, there's data, but they were all tough, I'll tell you. I'm not saying they were easy. And it took me a long time to get them there.
Heavy methamphetamine users is in the chat.
Oh my God, heavy meth users. All right.
He loves
So,
it.
I do love to talk about this, sorry. So, when people looked at a survey of chronically homeless people in Miami, the original report was that 85%, this is chronically homeless, had serious mental illness. Carol North, who comes out of University of Texas, went back and looked at this. And actually, it turned out that with better questioning of these people, only about 40% had straight SMI. What did the other 40% have? That looked just like schizophrenia? Heavy meth use. It really looks almost the same. I mean, it's just, could you imagine just putting this incredible amount of dopamine in your brain and just making your immune cells in your brain overactivated and chewing on your brain? They lose tremendous amounts of their CNS. And if they keep using it, it really makes it looks indistinguishable from any other chronic psychotic disorder consistent with paranoid schizophrenia. Having said that, if they stop and you start back and you put them on clozapine and they're young enough, you get recovery. I mean, will they return to their pre-morbid state? I've never seen that, to be honest, but I've had just a handful of former meth addicts. And, and also they're 3 to 5 years in. So who knows, 10, 15 years down the line. I mean, the brain we're realizing is just incredible, the amount of neurogenesis that goes on in an adult and the repair of pathways. So we'll see. But yeah, it's heavy meth and, and psychosis is a bitch.
Yeah. I think the last question for you guys, because I appreciate your time, but I want to be respectful. Does the entire nation have a psychiatrist shortage or just Illinois? I think we could definitely all use more psychiatrists. And Dr. Chern may have an idea. I know Dr. Olson had to drop, but are you seeing more people going to psychiatry or less, or are there just nurse practitioner psychiatrists now?
I think we are
Definitely
really,
more. Sorry, go Dr.
the short anyway, I think we're in a better situation here in Arizona, but we're really short anywhere.
Yeah. But they're finally matching the programs. I know that for a fact. I remember Tom Insel wrote a piece back in 2011 talking about psychiatry and just the absolute, they were, not the exemplary medical students, first of all, and two, they weren't matching programs. So there was tremendous, need to fill slots, and we were filling slots with anyone that could get a license. And a lot of and there's some exceptional psychiatrists out there, but a lot of psychiatrists, especially taking care of the sickest patients that were at the large institutions, were being taken care of people that otherwise couldn't get into the United States. And the only way they got in was, and I'm not, you can read Inzel's original piece, was through programs just because they needed bodies to fill. And so it is problematic, and
And how much do they teach clozapine in residency?
they don't teach clozapine in residency programs anywhere.
Oh, they do. They do.
They do?
Actually, I had a great experience when I was in residency training.
Where were you? Where, Dr. Turin, where did you train? I mean, where was
I
your?
think one of the hospitals was Columbia University.
Oh,
So,
Columbia is different, yeah.
We had a social worker who actually had psychosis, and she
Yeah.
wouldn't take any medication, and psychosis has been resistant to treatment. Of course, being the new person there in residency, you get the more challenging cases.
Right. Oh, there's
So they sent me the person, and they didn't tell me about the background, and because they're counting the minutes before the patient would explode in anger, but she did not, because I told her outside this room, other doctors think that that you have no medication that will work, but I think this clozapine can work. No, she said everything doesn't work. So I said, let's try to prove to them that this clozapine will not work. Let's try it first so we can tell them this doesn't really work. So she agreed to the trial to disprove that it will work, and it worked.
It worked, yeah. No.
But so they were surprised. What did you tell the patient? I just, took her side, and we were together. We were against you in trying to prove that this will not work. So that's a good story about clozapine.
It is. Oh, Columbia and the Psych Institute are wonderful places. Yes, and we've worked with them in the past. I mean, UCLA. There are centers of excellence across the country, but surprisingly, or not surprisingly, it's not universally treated. And again, if we had our way, there would be much greater exposure.
And then we have a shortage of psychiatrists, and then with the small number of people going to psychiatry, it's even worse in terms of attracting people to public service psychiatry, because there's less people and less people try, and of that low number of people trying, they sort of fall, through the years they have gotten to private psychiatry or the VA, and so very few of us are operating here in the Maricopa area.
So what do you think are the biggest barriers to using clozapine?
I think it's in the fear. I've encountered cases where the patient just covered in fear of having to have a blood draw every week, and it's kind of like if we can make it more humane and less painful for them to get the treatment, well, let's do it. Why not?
Or just don't test them.
But yeah.
It's totally unnecessary. We don't test Zyprexa patients at this insane level.
Exactly. We to a certain extent, I think we have to review the data that we have through the years, because we have been doing this for so many years. Weekly blood draw, every other week. It's just and perpetual. They never get off the blood draw. It's monthly at best. And I think we have to review the data that we have accumulated through the years.
Right.
And then come up with a plan based on numbers.
Yeah. So
not fear.
Right. The problem has been that people, until very recently with the revised REMS, they used to stop clozapine when they would see a downward trend of neutropenia. And the data has already come out conclusively that trends are meaningless. The other problem in the COVID era, which thank God seems to be abating, is that there is more neutropenia, not agranulocytosis, not less than 500, but neutropenia less than 1,000 is incredibly common with COVID. And I've seen on a personal level in our practice of 200 kids, 3 kids that we were starting that were in the hospital that got COVID, all dropped down, all had their clozapine stopped. And we had to restart it and start all over again to the detriment of these kids. So the testing, and this is Taylor's point in his 2022 paper, there were so many more false positives that led to the cessation of clozapine to the tremendous detriment of the patient than the true agran. So we always say 0.23%, but as Rachel pointed out, there was only 1 kid that was less than 44 that developed severe neutropenia in that population of 15 plus years of 3,400 patients. How many people completed a suicide because they didn't get clozapine? You know, we're talking about probably several hundred. I mean, the math does not add up in any way. First year of illness, we know that the mortality is anywhere from 22 to 89 times that of the general population with psychosis. Much of that driven by suicide, substance abuse, and accidents, all things clozapine would significantly impact. And what are we doing it for? The 1 in 10,000, 1 in 100,000 individuals that may develop or die from that 1 in 100,000 versus losing thousands. It makes no sense. I mean, the numbers are overwhelming already. That's why I'm hoping the FDA will listen.
It's like we're living in fear and we're not using something more often, you know, an intervention that can possibly help more people than hurt people.
Right. And the problem is, you know, there aren't enough psychiatrists, but most psychiatrists don't really treat people with psychosis if they're in private practice. It's really kind of unusual. They treat depression and anxiety, OCD, ADHD, but you'll find very few private psychiatrists who are comfortable treating people with psychosis. And if you don't do it, you'll never become comfortable doing it. So it's, you know, so there, but we run into a lot of nurse practitioners, psychiatric nurse practitioners, who are becoming more comfortable with clozapine. So then hopefully that'll take up.
And they have numbers. I mean, because we really need numbers, and there's so few psychiatrists out there.
Yeah.
And again, unless Donna comes up with a decent model of reimbursement, heck, I wouldn't have been doing this if it wasn't for my son. I'm making half to a third of what I used to make, taking care of and working more hours now than ever. But you know what? Some of the most gratifying work that I've ever done. Thank God I made a lot of money when I was a nephrologist, so it's tiding me over to doing this psychiatry stuff.
Okay, well, with that, I want to thank you guys. This was great information. You're all welcome to stay on if you'd like, but we're going to give the last, say, 15 minutes to families right now that are going through difficult situations. Typically, we have our REBA on, and we're going to invite the other REBAs, but the person that's always on is on medical leave, and then Blythe could not attend this week. And then we usually have representatives from various provider agencies. And all of us as family members try to help people struggling with tough situations. And we usually come up with some solutions or at least some ideas. So you're welcome to stay on, but now I shut the recording off so people can speak openly and not feel like they're being recorded. So I'll turn that off now.